still kind of popping in. We've got our state government shut down at noontime today, and a bunch of places have. So we are okay. We're going to record this because we also know that a number of people are probably unable to come because of the storm and everything. But thank you so much for joining us. So Dr. Frieden served, as many of you know, as the director of the CDC when I got to know him, because he was the director of the CDC during the H1N1 pandemic. He was also, before that, served as the commissioner of the New York City Health Department when Mayor Bloomberg was mayor. And earlier in his career, he worked with the government of India to improve tuberculosis care, a program that prevented millions of deaths. He led efforts to stop the largest outbreak of multidrug-resistant tuberculosis ever to occur in the United States. He's also been very well known to leading efforts to reduce tobacco use, stop epidemics of Ebola, and other deadly diseases, including those obesity related. And today he has resolved to save lives, which partners with more than 50 countries to accelerate action against the world's deadliest health threats. And his new book, which I'm just holding here, A Formula for Better Health, How to Save Millions of Lives, Including Your Own, shares very practical lessons that empower individuals as well as communities to create a healthier future. And the proceeds from the book actually go to projects working for health around the world. And we have bought 25 of the books to give out to participants who are here live with us. So we will get started. So I'm going to toss the baton to you, Dr. Frieden, and thank you again. We are so honored to have you join us for our MaineHealth Public Health Grand Rounds. And we have a number of distinguished people too from Maine in the audience too. So I know that they're excited, including some other prior state health officers and dean of one of our medical schools and things like that. So thank you so much. And a number of people from around Maine, we're really excited to see you all. Also people who work in our ethnic community-based organizations and other community-based organizations whom we partner with a lot in public health. So thank you so much.
Terrific. Well, I'm really looking forward to the conversation. I know that Maine has been a pathfinder in many areas. I want to kind of share with you in about 20 minutes or longer, actually, what this formula is, because I think it is a new approach. It's an approach that has been proven to save millions of lives. It's an approach that can save millions more. It's a formula. It's see, believe, create. 3 different aspects. Now, in thinking about this, I thought, let me tell you of a painful moment in my career. At the height of the Ebola epidemic in West Africa, our team was working around the clock in Sierra Leone, Liberia, and Guinea. And in Sierra Leone, the team was working about 10 o'clock at night, and they had a driver because they were in the office. They had to go back to the hotel later. And someone rushed in and said, the driver is bleeding. This was the height of Ebola. Driver was bleeding from his mouth, and they didn't have any safe resuscitation equipment, and the driver died. But it turned out he didn't die from Ebola. He died from untreated hypertension. He had hypertension, a stroke, seized, bit his tongue, and died. So this was a preventable death. And a vivid reminder that the challenges we face are both infectious, like Ebola or COVID or TB or HIV with your outbreak there, and non-infectious, including high blood pressure and cancer and environmental toxins. So how could the formula for better health, see, believe, create, have changed that reality and prevented that tragedy? Well, see is seeing the invisible, and this is public health's superpower. Interestingly, the first presentation of that was by a cloth merchant who was a member of the ruling council of London named John Graunt in 1662. And it's really remarkable what he did. He said that he had produced a booklet and he said it's a new thing. And it really was. As far as I can tell, it's the first epidemiologic analysis in human history. It's natural and political observations on bills of mortality. And he analyzed trends. He saw emerging health problems. Rickets increased. He saw how different diseases affected the economy differently. Plague killed between 1 and 82% of people in different years, but epidemic fever, whatever that was more economically disruptive because so many people were sick that there were, quote, scarce hands enough to take in the corn, or corn was actually harvest. He noted that coal was beginning to be burned then and thought, it seems to be increasing death rates. He asked the question, uh, um, what's the most important single indicator of health of a community? And he wrote the following: no person can be said to die from old age who is much less than 70 years old. It follows that if in any country a higher proportion than in London live beyond 70, that country is more healthful than our city. Uh, in his day, only 7% of deaths occurred among people over age 70, compared to 70% in the US today and 80% in the healthiest countries. And if you think about that number, it's really quite interesting because nearly all of the under 70 deaths are preventable with current technology. Not all of them. They're pancreatic cancer and things like that, which we don't know how to prevent. But if you think about the rates and you can age adjust in different ways, you really have the potential to have an overall indicator. And if you think about an under 70 death as being basically a never event, it's interesting, right? So Maine has one of the lower rates adjusted, but not the lowest. Hawaii has a much lower age-adjusted rate than any other state, the healthiest state probably, and California, Washington, and others. So, but the bigger point is, how do we make sure that there is an assessment, that we see what the reality is in terms of health? Surveillance can help us see how and where people get sick, but it can allow us to see trends, whether it's in opiate deaths or microbes. It can allow us to see drug resistance, and we can see in better ways than ever before through DNA fingerprinting. We also can see toxins, including invisible toxins. And because it's a public health group, I'm going to actually tell you, I got made fun of by a friend of mine for doing this, but my very favorite part of the book is an end note. And it's an end note not even written by me. So I learned more and more about Alice Hamilton. She was the first female professor at Harvard University, where I happen to be at this moment. And she basically founded occupational health in the US, and she figured out that lead poisoning was really a big problem. And, our current challenges are things like PM 2.5 that kills 100,000 people a year, maybe fewer in Maine with your clean air, but microplastics, nanoparticles, endocrine disruptors, we really don't know that. So seeing the invisible, we're still on C, between see, believe, create. We need to see the harms that are there, and we need to help others see it. So I'm going to read you an end note from page 212. Alice Hamilton, when she could regulate, she regulated. When she could get laws passed, she got laws passed. When she could organize unions to demand safer working conditions, she did that. When she could do none of those things, she showed such astonishing tact. So she's writing here to the manager of a factory that had a lot of lead poisoning. And this manager was very stubborn and unwilling to listen. And I want to point out, she's going to talk about immigrants here because the manager was blaming it all on immigrants. She was an advocate for immigrant rights, so much so that the FBI had her under surveillance for decades for that reason. Here's what she says. My dear Mr. Foster, I've just been writing to the Secretary and Treasury of the company about our conversation last Friday, and he asked me to put my recommendations down on paper. So what she's saying here, she's saying, I'm telling you, boss, you better pay attention. Now, I want to write to you also because I feel you are really the one upon whom the reforms depend. The factory which is safe and clean is the factory which has a foreman who wishes it to be safe and clean. He is the most important factor, for he is there all the time. She's flattering him, but she's also making sure he knows he's accountable. As long as your roller room has piles of white lead on the floor and in open trucks, you will always be having lead poisoning. You see, you'll never be able to make your men careful under those circumstances. I know 2 white lead factories, old ones at that, where you would not know what was being made in the place, where the floor is so clean you could eat your dinner off it. Your place is filthy, guy. That's what she's really saying. I've been able to find only 3 cases of lead poisoning at a nearby factory that has those better practices, and 27 from your factory. Yet both factories employ the same number of men. Don't deny it. You got a big problem, buddy. It is slow work and difficult to train a lot of foreigners to take care of themselves, but I know you can do it. And I'm sure there's no man in the white lead business who is more genuinely anxious to protect his men than you are. I mean, I just think it's wonderful, right? It's just such a tactful, strategic approach, and she is calling to his better nature and his better angels. So seeing is about seeing microbes, seeing trends, seeing toxins. It's also about seeing program performance. When we did a nicotine patch giveaway program in New York City, we did it through the 311 operator, and we had done a community survey, and we had seen what the smoking rate was in every zip code of the city. And so each night we downloaded the data of who called in for their free nicotine patches and gum. And the next morning we sent college kids out with leaflets to the underrepresented communities to say, hey, you've got a time-limited effort. You can get more people. You can call today. So we were trying to address the equity issue in real time. Seeing program performance is very important. The road to hell is paved with good intentions, and the road to public health failure is paved with naivete, not seeing things. But the other thing that we really need to understand, and this is something which I went into in some detail in the book, is the Cassandra curse. We have a Cassandra curse in public health. Cassandra was a priestess from Greek mythology. She could see the future, but she was cursed. Nobody believed the predictions she made, and so those predictions came true. What a horrible situation to be in, right? That you know that people are going to die from something. You tell them, do this, and that won't happen, but they don't listen to you, and tragedy ensues. Well, that kind of sounds like public health, doesn't it? We have had a public health Cassandra curse for many years, but now we have better diagnostics, better treatments, better vaccines, better tools than ever in human history. We can break the Cassandra curse. But to do that, we really have to understand why it exists. And one of the reasons it exists is that our perceptions of the world, of reality, are incomplete or inaccurate. Our perceptions of ourself, of our world, and of the future. Of ourself, we may not see how important social norms are in determining our own behaviors. We may think it's all what I decided. But, you know, it wasn't so long ago a family would get into their car, drive to the beach, put on suntan, not sunblock, but suntan lotion, have a few beers, get back into the car, not put on any seat belts, drive to a restaurant, smoke and drink in the restaurant, not put on get back into their car, not putting on any seatbelts, and drive back home. That was a normal behavior. Um, that's not a normal behavior now, and that's why we have way less smoking, way less skin cancer, way less smoking in restaurants, way less drinking and driving. These problems are still problems, but they're no longer considered acceptable. And there are a lot of ways that companies like the tobacco industry engineer products so that what we think is our free choice or do advertising is not. So one cause of the Cassandra curse is that we feel that we have unfettered free will, but that's not true. Another cause is that our perceptions of the world are inaccurate. We don't see the economic interests driving misinformation or economic structures of our healthcare system that make it difficult to prevent disease. There are false alarms that make us kind of hardened to risks. And there's a prevention paradox. This is a very important concept that Jeffrey Rose outlined, that the biggest health improvements or harms come from small changes to many people rather than big changes to a few people. It's a very interesting epidemiologic concept. So if you reduce lead poisoning for everybody a little bit, you get a massive benefit, way bigger than clean up a couple of lead poisoning areas. But there's a political corollary of the prevention paradox, which is that there are always concentrated losers and diffuse winners. And so we just
I'll check in later.
We don't have the ability to have a clear route to progress in public health. We will always be the underdog. And so that's a structural problem. We get used to it and figure out how to break that curse. The other inaccurate perception is hyperbolic discounting. We shortchange the future. I've assessed this for my own calendar. We tend to discount things inappropriately into the future. So the way I use this in my personal time management is I used to accept speaking engagements, and then I'd get there and I think, why did I accept this? And the reason was it was 6 months ago, and in some part in my brain, I couldn't understand that something that was 6 months, in the future will eventually be tomorrow. And so what I now do is if I have an invitation, I say, if it were tomorrow, would I do it? And if the answer is no, I get out of it. I can. You guys, I wanted to speak with, so you passed the hyperbolic discounting test. So that's almost all of the see the invisible, but it's not the last part, which is seeing the path to progress. This is about technical rigor, and it's a lot harder than it sounds. Follow the science is not sloppy, is not clear. It's not a clear way of thinking. Science doesn't tell whether you should do something. And technical rigor requires really deep knowledge of each source of data, both practical and academic. In chapter 3, I outline the tools for technical rigor, burden times amenability. What are the big problems we can do something about? The public health, or the health impact pyramid of what are the implications of what we can do for society. What's a technical package that will deliver the most benefit? And the importance of humility. Science doesn't breed certainty, it breeds humility. And if you think about what Nancy Messonnier said in 2020, in February of 2020, she said, despite years of planning, we need to remain humble and understand that we may not have planned for everything. I think this comes down to the need to be humble. Disruption in everyday life may be severe. So that is true science. This is what we know, this is how we know it, this is what we recommend, this is why we recommend it. Another great public health success story has to do with learning how to prevent SIDS, sudden infant death syndrome. Ed Mitchell in New Zealand figured out that it might have been that babies were being put to sleep on their stomachs, and putting them to sleep on their backs might prevent it. The evidence was strong enough for the New Zealand government to recommend it to parents. And when they recommended it and parents did it, there was a dramatic reduction in SIDS deaths. So this wasn't evidence-based practice, this was practice-based evidence, and we need more of that. So see, believe, create. That's the C part of it, seeing the invisible, the public health superpower. The next is believing that we can change it. Because if you don't believe you can make a difference, you're not going to make a difference. And that starts with shattering an illusion of inevitability, seeing past progress. Hey, the world hasn't always been this way. Cardiovascular deaths in the US decreased by 2/3 between 1960 and 2010. 20 million people didn't die young for that reason. But there's a history of the New York City Health Department that says encountering apathy, ignorance, and avarice is the lot of all conscientious health officers. As preventive measures in the health area are more successful, the public is less inclined to support the programs which ensure this success. Public health's Cassandra curse is even worse than Cassandra's, because not only do people not believe us about future tragedies, they don't recognize that we've prevented past tragedies as well. 8 billion people in the world, not one of them woke up this morning and said, thank goodness I didn't die from smallpox yesterday. CEA Winslow, who created the American Public Health Association with others, wrote, if we had but the gift of second sight to transmute abstract figures into flesh and blood so that as we walk along the street, we could say, that man would be dead of typhoid fever. That woman would have succumbed to tuberculosis. That rosy infant would be in its coffin. Then only should we have a faint conception of the meaning of the silent victories of public health. At Resolve to Save Lives, we periodically publish epidemics that didn't happen to give credit to teams around the country and around the world that have protected people in ways that they'll never know. I think one of the reasons we don't discuss past progress in public health is that we think it may lead people to relax and say, we've done enough. But I think that's misguided. I think it can lead to a sense of possibility and urgency. Things can be bad, but better. Look at tuberculosis or smallpox or trans fat. We've made progress. So in the believe part of shattering the illusion of inevitability by believing, recognizing past progress is one part of it. The next part of it is making phased further progress. And at Resolve to Save Lives, we do that by going from prototype to proof of concept to scale. There's a really bad disease affecting many of our programs. It's called pilotitis. That things never get out of the pilot phase. And the way to avoid pilotitis is to think about phased progress. What comes after phase 2? I'm phase 1, right? Phase 2, right? And to do phased progress, find phase 1 areas that have good leaders that you can supervise regularly and that are really possible to work well with, always more than one, because one might idiosyncratically do well or poorly. So we're in believe, out of see, believe, create. In the believe part, recognize past progress, make phased further progress, and cultivate optimism. Cultivating optimism is really important. Misplaced optimism can be very harmful, but it's really important, especially for groups that have lacked political power in the past, to see that differences can be changed, that progress is possible. And when we fail at Resolve to Save Lives, my group, we have failure festivals. All right, what went wrong? What do we learn from it? So that we can encourage the people who tried and didn't succeed through no fault of their own. Now, it is important to avoid misguided optimism. And in the book, I talk about the misguided efforts to eradicate malaria and the Aedes aegypti mosquito in the 1950s and 60s, those really undermined public health. Why? Because they didn't rely on a clear vision of the path to progress. When Bill Foege was in India working on smallpox eradication, he was doing a little bit of everything. He was purchasing needles and renting jeeps and communicating with policymakers and training doctors and vaccinating children. And someone came and said, "What's your job description here?" And he said, "Resident con man. My job is to keep people believing we can do this." But it wasn't a con. It was uh, building confidence such that 200,000 healthcare workers in more than 70 countries found more than 10 million contacts of smallpox patients within 5 days of exposure and vaccinated every one of them to eradicate smallpox forever. So that's the believe. See, believe, create. The next part of the formula is creating a healthier future. Seeing the invisible is hard, believing the impossible is hard, but creating a healthier future is by far the hardest. Bill Foege was asked, after the eradication of smallpox, what next? And he said, the eradication of bad management. And that's the start of the create component. Create requires structure. Knowing what works isn't enough. We have to implement it at scale in the real world. And to tell you about the scariest moment of my career, I was CDC Director. Ebola was spreading in West Africa. We were beginning to get it under control, but then one person went to Lagos, Nigeria, and we had additional cases there. Lagos is larger than the 3 West African countries combined and has many more flights in and out and much more travel and many more connections. If Ebola had gotten out of control in Lagos, it would have been out of control in Nigeria and in Africa, not just for months, but potentially for years. And it wouldn't just have killed people from Ebola, it would have shut healthcare systems, more malaria deaths, more maternal deaths. It was really scary. And initially, the person put in charge of the outbreak response was not very competent. And my team called frantic because they had just spent hours debating a completely pointless question of what to do with an embalmed corpse that had transited through Liberia but was zero risk. And while they were doing this, doctors and nurses who had been exposed were dying in the back of ambulance because there was nowhere to put them. With a strategic call, we had a very effective Nigerian leader put in charge of the response. He implemented an incident management system. They rapidly found 18,000 contacts, visited them in their homes, built an Ebola treatment unit in 10 days, educated and informed the community, tracked points of entry and exit, and stopped the outbreak within weeks. When 2 patients fled to a nearby city, they repeated the whole thing and stopped it there as well. So we need systems that work both in crises and not in crises. And that means thinking about what are the non-urgent but important issues that need to be dealt with. Organizing means getting the technical, operational, and political details right. And it starts with simplicity. Simplicity is really important. Simplicity allows systems to succeed. Complexity is one of the major causes of pilotitis. At Resolve to Save Lives, we talk about simplicity, speed, and scale. One approach, which I think you should consider looking at in Maine, is what's called the 717 target. We suggested this a few years ago. It's now in use by more than 50 countries. And what it does is it takes every single outbreak and it asks, was it the public, was it within 7 days, reported to public health within 1 day, all essential control measures in place within 7 days. 717, yes or no. And it's not about blaming. It's about finding out what are the bottlenecks, what are the enablers, what worked, what didn't work, so that instead of planning and more planning, we have find a problem, fix a problem as an approach for how to make sure that with each outbreak we get better at it. Simplicity is really important. I would say on high blood pressure is the leading preventable cause of death in the US and in Maine, and we don't do a great job of treating it. And the indicators we use to track it are often very inaccurate because we don't have many state-specific health and nutrition examination surveys, and the medical indicators often overstate control by 20 or 30 percentage points or more. So simplicity is important and communication is important. Communication isn't about programs. Communication is part of programs. So organize, simplify, communicate, and then overcome the barriers that will always exist because of that prevention paradox. That means finding who are the winners and losers, who are the deciders and influencers, who are the advocates and what are the partnerships, what's the timing we can use, and the pragmatic approach to progress. Now, these are hard times for public health. We've seen funding cuts, eroded authority, political and even physical attacks, but we've been in hard times before. Before World War II, the CDC didn't exist. State and local health departments often innovated and led the way. Smallpox seemed inevitable. Multidrug-resistant tuberculosis seemed uncontrollable. Trans fat, we didn't even know what it was, and it was killing 500,000 people a year. Ebola seemed impossible to control. We didn't know that babies were being born with birth defects because of a folate deficiency that's now virtually gone. Roads have gotten massively safer. In the 1980s, the federal government was asleep at the switch with the HIV epidemic. In the 1990s, when I was starting out as an epidemic intelligence service officer, 25% of adults and 36% of kids, teenagers, smoked. Facts are stubborn things, and even if they're denied, suppressed, twisted, or cherry-picked, they remain facts. And one fact is that people want to live a longer, healthier life. I mentioned that John Graunt in 1662 wrote the first treatise on epidemiology and suggested that coal might be unhealthy. Well, last year, for the first time since 1662, England burned less coal than in 1662. The cost of solar energy has come down by 90%. Teen smoking, which was at 36% when I was an EIS officer, one of my fellow EIS officers did a study that showed that 6-year-olds recognized Joe Camel more than Mickey Mouse. Now teen smoking is at 4%. Telemedicine offers a huge potential for rural health. AI is transforming our world, and yes, it can do harmful things, but it can be great also. We need to build forward in public health for the next generation. We need a public health that's faster, better at listening and communicating, more connected with stronger alliances, especially to primary health care, and that delivers results that people see in their own lives and appreciate. So that's a whirlwind tour of the formula for better health. I think it is a somewhat new way of looking at public health and of assessing and evaluating how we can do better. I also have what it implies for personal health as well. So thank you very much, and I look forward to the conversation.
Oh, that's wonderful. My gosh, I was taking notes, but I know a lot of this is in the book too. So thank you so much. That was fantastic. Well, anybody is welcome to put a question in the chat, or also you can unmute, but raise your hand electronically so we know to call on you. I'll start out if you don't mind. I love your, this see, believe, and create those that framework. And was just wondering, it seems like we in public health get a lot of flack sometimes from the public about always warning about something, and particularly those that are the silent issues, as you mentioned, like warning about hypertension or warning about some disease that people aren't seeing. How do we overcome that? You kind of alluded to in the last couple of minutes about, you talked about some of the successes. So is it that too, that we should be communicating not only about the warnings, but also about the successes, or any other suggestions?
Yeah, when I was health commissioner in New York City, one of my assistants said, in a coffee shop in New York City, a double no fun is a decaffeinated coffee with sweet and low. And all too often, public health is considered the double no fun. But if you think about it, if we're telling someone to do something, we have failed. Because public health succeeds when we make the healthy choice the default value. The fact that we're having to tell someone to do A or B, that is an indication that we have failed. If we're telling you to boil your water, it's because we failed to keep the water clean. I think I've learned a lot from Frank Luntz. He's a communications expert, and there's certain phrases that go over well and certain phrases that don't go over well. One that does go over well is "you decide." So the instead of saying you should do this, saying here's the facts, you decide. That's much more powerful. Also, the importance of listening. The single most effective way to change someone's mind is listen with sincere curiosity to understand how they see something, what they're hearing, what they believe. Then you can use that to frame a message and to identify a messenger that can get that message across. There's not a lot that we should be telling people what to do. It's more structuring things so that if you go with the flow, you'll end up healthy. And you empower people with information on how you can be healthier. One thing I did with the book is I put in, and I was kind of shocked that I couldn't find anywhere an overarching summary of what works to live a long and healthy life and reduce dementia. So Appendix 2 in the book does that. And it's what's called a super table because it has many columns and it gives an estimate of how many months would this gain you if you do this in healthy life expectancy. It's an estimate, but it's a defensible estimate. It gives you what's the strength of evidence, virtually certain, likely, possible, or no evidence. What's the strength of evidence that this will lengthen your life? What's the strength of evidence that this will reduce your risk of dementia? And what's a tip for how you can do this readily? And it was an experience to do because when it comes right down to it, about personal health, there are really 6 things that are by far most important. Control blood pressure, ideally to 120 over 80 or below. Control lipids, ideally with LDL and ApoB less than 70. The wonder drug, physical activity, at least 30 minutes, at least 4 days a week, rigorous enough, brisk enough to get out of breath so you can't sing. Get enough sleep, at least 7 to 9 hours of sleep. Avoid toxins, tobacco, alcohol, PM 2.5, and healthy nutrition, which isn't as complicated as it's made out to be. There are 3 things you need to eat more of and 3 things you need to eat less of. You need to eat more fiber, more potassium, and more fruit and vegetables. And you need to eat less sodium, less processed meats, and less free sugar, especially soda. It's not that
That's
complicated
great.
and hasn't changed that much. We have a couple of hands up.
Yes, and it's on page 207 for those of you who do get the book from us or have the book. So thank you. You do have some
Oh, I
questions.
just have seen the chat. I'm sorry.
And there's somebody raised their hand too. Is it Tim? Somebody, Tim, did you want to unmute?
Sure, I'll jump in. So wonderful talk. This is just delightful. I have two kind of mixed questions and comments. And I'd start off with saying that, as you may be familiar, the vision for MaineHealth is working together so our communities are the healthiest in America. And I feel like in many ways that's embraced. And I really admire many of my colleagues. I'm a family physician in a small town on the coast of Maine. But I feel there's things that we could do better at. And the two things are that there currently is nothing in our goals around preventive health for decreasing rates of smoking. And to me, that seems like a glaring omission. I'm wondering if maybe you could comment on that. And then the other thing that I struggle with is that I think we do a lot to improve the health of the patients who come to see us, but I'm not feeling like we're necessarily, maybe I'm not aware of things, but I feel like there are probably a lot of opportunities that we could do things to help the health of the people who don't come to see us.
Wow, what great points. And thank you for doing primary care. It's so, so important. And we need to have, and I know, Dora, I was reading your article yesterday about primary health and healthcare and public health and how to intersect. And I know you're really at the cutting edge of thinking about these things. And I looked up, if I saw correctly, you just increased your tax to 350, but the 70% target of WHO would have you at 545.
Yeah.
So you're far away from optimal. There is a technical package for tobacco control. It's Empower. I helped work with WHO on this, and the main issues, not the major issues are tax, smoke-free, all public places, hard-hitting anti-tobacco ads, bans on marketing and promotion and limiting places of sale, and offering cessation assistance. And no area has really been able to offer cessation assistance enough to move prevalence down. A lot of people have tried it. We did some in New York by giving away patches and gum through 311 to 30,000 people a year. Do that for 10 years and you'll affect prevalence. But it is the structural changes that reduce smoking. And there are some cutting edge things there. The people we don't see, that's so important. It's such an important point. I mentioned hypertension. So in the UK, their HEDIS equivalent says that they're at 90% hypertension control. Their community surveys, there are two of them, one 15%, one 36%. In the US, our HEDIS is 65%. We're actually at 45%. And 90% of the people who are uncontrolled for hypertension have healthcare coverage and have seen a doctor in the past year. Kaiser Permanente gets this right. They control 90% of their patients' blood pressure, including all races, all ethnicities, Medicaid and non-Medicaid. Why? Because it makes financial sense for them. If they control blood pressure, they make more money. If they don't, they lose money. And we need to figure out how to make that our health system. I mean, just imagine, Dr. Goltz, you're a primary care practitioner, you said?
Family medicine.
Family medicine. And how many people in your practice?
I have about 1,200, I believe.
And in your community?
Our town is only 2,000 people, but we have a big catchment area.
Okay, so 1,200, and about how many are adults? What proportion?
About 97%.
Okay, so you've got 400 hypertensives in your practice. And as a practical matter, we work with more than 40 countries on hypertension control. And I think the way to assess this is to look at how many people are on treatment and controlled. And you should be able to get that number up, up, up. And then you can think about your catchment area. You could have all of the providers do that. And you can say, well, how many do we have? You can estimate based on epidemiology how many hypertensives there are in the catchment area. Get all of the providers together and say, okay, let's collaborate and try, because it's in all of our best interests. So that's a specific thing. But on a health system approach, how could we have it so that if you do that, you're going to prevent a lot of heart attacks and strokes and kidney failures. What if you made enough more money that you could hire an extra outreach worker or office person to call all the people not in control, give them blood pressure measurements, have a pharmacist up titrate if needed, and get control. So if this was really important economically, it would happen. It doesn't happen in this country because it's not really important economically. Now, I'm going to try to answer every question that's been raised.
And I'll just point you to Mylan Cohen's asked a couple questions. He's a cardiologist and is a public health physician. So he has some, I think, some couple of interesting questions.
So one of them is what's happening in Washington with vaccine recommendations. I mean, obviously, if someone hijacks the CDC and promulgates non-science-based recommendations, our responsibility as public health professionals is to follow rational recommendations. I have a piece in JAMA about the mistake, the abdication of responsibility with COVID vaccination. I have something coming out just this morning about hepatitis B. We've tried this. It didn't work. It's not going to work again. This would be leaving millions of children unprotected for no good reason if they get away from the birth dose. I think, in terms of the GLP-1s, I don't see them as yet going to make a major difference. I think they're already bending the curve on obesity, but 2/3 of people stop them within a year. I think we're going to see new GLP-1s coming in, which are oral and better tolerated and more targeted. But hey, statins are also remarkably effective, and we don't have those out to everyone. Antihypertensives are remarkably effective, and we don't have those out to everyone. We've got the cost of hypertension treatment down to less than $5 a year globally. Statins are a penny a pill, and we still don't have those into people. So I think the GLP-1s are a breakthrough drug. They're really, really impressive. But I think it's a broader issue of how do we get effective care to more people. In terms of the loss of trust in science and alternate players, trust doesn't get built back quickly. It's slow, and it's going to take time. And it's going to start with listening. What are people hearing? Who can they hear from? How can we strengthen the places where people are going for information? Rather than trying to get them to come to us, let's go to where they're going and try to get that more science-based. So I think there was another hand up.
That was my hand. I think some of the things folks have already said, but I was wondering as I was listening to you, how do we combat this misinformation and disinformation that is running so rampant that people are, it sometimes seems like a uphill battle to fight that information, because people already come with a preconceived notion of what's about the information they're going to receive. So that's the first thing I wanted to say. And the second part is, are we really administering healthcare, especially public healthcare, correctly? For example, I think of the provider who has 1,200 people in his practice and in his community. And I look at that personally. I know for myself, whenever I go to my provider, it's like I'm meeting him all over again every single time. But, there was a time when we did public health differently. People went to
Yeah.
people's homes so you could see how they lived, what they're eating, what they're actually doing. Are they stuck in that couch the entire day? And then they come to the office and tell you they've been walking 30 minutes every day. You can tell that difference and you can really tailor that care. So the question is, are we really doing and administering public health correct?
Yeah, so two really tough questions. On misinformation, this is not going to be easy. We need to take a multi-pronged approach, improving education so people understand how science works, strengthening the institutions that provide information, whether it's news media or science-based. Also, building trust kind of drop by drop, understanding it's going to take time, learning to speak in social media. During COVID, when CDC was silenced, I, became a message disseminator on Twitter, and I learned to speak Twitter. Now I need to learn to speak video, right? So this is what 40% of people are getting their news from YouTube. We should be going to where people are rather than expecting people to come to us. I'll just tell you a quick story about Costa Rica. They have a very good primary care system, and I was seeing it at one point. And as I walked to a patient's house with the community health worker, a dog started barking, and the community health worker said, "That dog doesn't bite." So not only did the community health worker know every family in his catchment area, he knew which dogs bit and which dogs don't bite. So what if we have a healthcare system that pays to keep people healthy? Then it would make sense to hire community health workers like that, to hire pharmacists to titrate people's medications. We have a very specialist, hospital-centric healthcare system. It would be very hard to spend more money on healthcare and get less than we get. In fact, no country in the world does it. Now, that's not a criticism of our healthcare facilities. If you have a complicated health problem, you can get better care in this country than anywhere in the world. I have no doubt about that. But I also have no doubt that I have what I call the saddest chart in the world. It shows from 1980 to 2020 what happened to healthcare spending, where the US went from a little above average to an absolute outlier, twice as much as any other country per capita on health. And at the same time, our life expectancy went from average to by far the lowest of all of the countries. Did I miss a question? Yes. What is going to happen with the pandemic, with CDC and AID being dismantled? I will say the current administration does seem to care about pandemic prevention. That's been a focus of their work in global health. We'll see how that happens. I talk in the book, chapter 9, about how to prevent pandemics and what we need to do next. I do think the 717 metric is definitely worth looking at in Maine as something that can be done there to reduce the impact of outbreaks. But we are in a different era. The first 25 years of this century will be seen as a golden era of global health. And what comes next? Well, that chapter is still being written.
There's also I think Laurel Rushton, who used to work at USAID, also has a question. Maybe you just answered it about
did it. I just answered it.
Yeah, okay, you did that, but thank you. That was.
I mean, what we're seeing globally is a real recognition that countries need to be at the center.
Yeah.
And countries need to set their own priorities and be accountable to their people of what they deliver in those. And we need to learn lessons of what worked well and what didn't work as well in global health programming. But I mean, what's happening to the US CDC is very, very concerning to watch. We've seen basically firing of all of the leadership. We've seen unprecedented firing of the person they just appointed as director, a scientist. We've seen a loss of about a quarter of the CDC centers. We've seen the departure of, half of CDC centers are being closed and a quarter of staff have left. And the implications on the one hand is that, state health departments will need to do more, but also states need to make it known very clearly that, hey, when CDC can't respond to an outbreak of HIV or to a lead poisoning problem in Wisconsin, this is not okay. It's not normal, and we can't let it seem normal.
What are your feelings about the role of public health and the social drivers of health, poverty, housing, transportation, food insecurity, and the like? And because as we've been screening our patients for social drivers of health, and then we also match those up with race, ethnicity, language, and geography, it's so striking how much of our health is really determined by those issues. And yet we struggle sometimes to figure out what is our role as healthcare, as public health, in terms of trying to move the needle on those issues. Any thoughts on that?
Yeah, I mean, not easy, right? Our zip code is more determinative of our health than our genetic code. And the public health impact pyramid that I had published way back talks about the biggest changes will be from social determinants. But good health programs tend to work at every level, from the most basic of jobs, economy, education, to pollution and clean water and air, to one-time interventions such as vaccines, to ongoing clinical care, including hypertension, diabetes, statins, to individual counseling. I think the challenge is it's often said that politics is the art of the possible.
Yeah.
Public health is also the art of the possible. And so you figure out where can there be strategic progress. It's not enough to say, oh, this is a problem. We have to, sometimes bearing witness is useful, but it's even more important to identify where there can be specific progress and then use a strategic approach with Chapter 8, how to overcome barriers. Who are the winners, losers? Who are the deciders, influencers? What's the timing and pragmatism and partnerships? Look, Coke and Pepsi hate each other, but they get together to block soda taxes. We can get together with lots of different groups to make public health progress.
That's a great point. And Sharon, probably we have time for one more question. Sharon McDonald, she and her husband, Gib Parrish, used to work at US CDC, maybe in the time you were there. I can't remember. Sharon, you can share that.
I see the question there. The state coalitions, and I know Maine is a big part of that. Thank you for doing that. On the one hand, there is no alternative to a federal system, right? There's nothing that any one state or coalition can do there's a Scientific American piece I just published last week about this very question. So it's behind a paywall, but we can get copies of that to you. But there's a lot that states can do. States can innovate. You can think about the new health. I was at the Massachusetts Health Department this morning. They said they actually have the contract in place. So if the Hep B vaccine birth dose is not available on Monday, they can place the order for it. So we wish this didn't have to happen. Some of what we need to do is to block problems at the federal level, to stop the destruction. The second thing we have to do is to patch where possible. And the third is to vision a new public health where we're going to be faster, better at communicating, with stronger alliances, and delivering tangible progress that people can see. All right, I'm going to have to stop here. Thank you all so very much.
Thank you so much. We really,
and I know Maine shows the way, so So we look forward to seeing lots of
Well-
more progress there.
Well, thank you so much again for joining us. It was a real honor to have you join us. And thank you, everybody who joined us on this. Anyway, take care. Stay safe with the snowstorm.
Thank you.
Bye-bye.